Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends. Thank you for joining us for another episode of Breast Cancer Conversations. I am so excited that you join us week after week. And I just want to let you guys know a couple shout outs. If you don't know already, hop on over to our website, survivingbreastcancer.org/events, and you will find the lineup of all of the programs and events that we offer virtually that are 100% free to support you no matter where you are on this crazy wild ride of breast cancer. Additionally, I would encourage you, we are really trying to grow our engagement and our connections on social media. So I will link to all of our social media in the show notes below, but please follow us on Instagram at survivingbreastcancer.org, all one word. If you're interested more in my personal life, you can also follow me and our co-founder William at Laura and Will on Instagram as well. We post a lot of stuff about just the life of running a nonprofit, working crazy hours because we all have day jobs as well. And we do this out of the passion and love for our community. We also love to eat food. And quick side note, we recently just got married. We eloped in the Grand Canyon. So lots of good stuff. Follow us at Laura and Will. If there's content or anything that you're most interested in, I love to hear from you. So feel free to DM me on social or feel free to send me an email at laura@survivingbreastcancer.org. We have an awesome lineup for you today. I am so excited because we are joined with Dr. Rodriguez, who is an oncology medical director at Natera. Natera is a company with expertise in cell-free DNA technology, which delivers platforms in prenatal care, transplant medicine, and oncology. Dr. Rodriguez is a board-certified medical oncologist and attended Baylor College of Medicine in Houston, Texas, where he completed his residency in internal medicine and fellowship in hematology and medical oncology. He was the recipient of a Komen for the Cure multidisciplinary breast cancer grant and specialized in breast cancer oncology at Baylor College of Medicine, where he conducted clinical research in ctDNA application in breast cancer management. Before joining Natera, Dr. Rodriguez practiced in Houston Methodist Cancer Center, where he was the director of the clinical trials office and led the triple-negative breast cancer clinic. Dr. Rodriguez is currently based out of Austin, Texas, and it is my pleasure to have him join us today. Welcome to the conversation. Dr. Rodriguez, I am so excited to have you as a guest on our podcast, Breast Cancer Conversations. This is a podcast where we talk about all things breast cancer. Nothing is off the table for us. We hear it all, we talk about it all, and most of us have been through most of it. So we're really excited to have you as an expert today to talk to us about a variety of topics, actually, as we take a deep dive into understanding surveillance and specifically around ctDNA and what it means for those of us who've been diagnosed with breast cancer, either in an early stage setting, 0 through stage 3, or at a late stage setting, whether you were diagnosed at the onset of metastatic breast cancer, which is also referred to as de novo, or if you unfortunately have metastasized from an early stage to a late stage cancer diagnosis. So a big umbrella, but to talk about, when you're diagnosed with breast cancer, your mind is just running through absolutely everything. And to really take a step back and say, is the medicine working? Are the treatments working? How do I know? Give me a scan. Let me know. I need answers. And so these are the things that we, stay up at night thinking about. And so I'm so excited to dive into these topics today. But before we take that deep dive in, I would love to give you an opportunity to introduce yourself and let our listeners know a little bit about you.
Yeah, hi. Thank you, Laura. And it's a pleasure to meet you. And thank you for having me to discuss these topics. My name is Angel Rodriguez. I am a medical oncologist. And during my training, I was very fortunate to have been the recipient of a Komen sponsored fellowship grant that allowed me to specialize in breast oncology and also train and do some research in breast cancer. And after that, I was medical director of a triple negative breast cancer clinic in Houston Methodist Cancer Center. And in that scenario, I was able to do a lot of clinical research, offering early phase and uh, clinical trial offerings for early stage and late stage patients with not just triple negative breast cancer, but all sorts of subtypes. And they're in that uh, role. I was also able to first get the experience of evaluating circulating tumor DNA as a potential tool to manage the care of patients with breast cancer. And that was going back to maybe 2014, and a lot has happened since then. And so I'm very happy and eager to share my experience and thoughts on the topic.
Wonderful. Well, thank you. And I appreciate you bringing your expertise to our community because so many times, we are bombarded with new lexicon, new words, new vocabulary, things I didn't even know I had to know when I was diagnosed with breast cancer. And so I think just starting off with some common definitions so we kind of have a baseline of what we're going to be talking about tonight is, how do you define recurrence and breast cancer recurrence? And then what does that look like in terms of, sometimes I hear progression as well. And so kind of understanding what do these terms mean, and we'll just start from there.
Yeah, I think it's a great question because as we introduce and learn about this new technology of monitoring the disease molecularly, even more new terms are going to be introduced. So we got to make sure that our foundation of the lexicon of the terms we use today is understood. And so the first one being recurrence, right? And recurrence, or recur means to come back. And the term cancer recurrence refers to the return of cancer cells after a period of time when it was believed to have been eliminated or under control. And it is typically used in the context of patients who were initially diagnosed with early stage disease or stage one, stage two, or stage three disease and underwent treatment with the intent to cure, right? And so these patients typically undergo the stage of or the setting of surveillance. And, unfortunately, sometimes despite our best efforts to eradicate the disease forever, recurrence can happen, right? Cancers can come back, and they can come back in the original site of where the tumor was within the breast, and that's called local recurrence. um, Cancer can come back regional recurrence, which means in lymph nodes within the area. And then finally, cancer can recur in a different part of the body, what we call distant recurrence, distance, far away from where the tumor started in the breast. And when distant recurrence occurs, this is now typically what we call metastatic breast cancer or stage four.
That's so helpful. And thank you for that thorough explanation as well. And that's a really good point, I think, to understand, recurrence isn't a uniform blanket term. And so that there's kind of these three elements of where the cancer can recur. Along those similar lines, I've talked to, friends in the community who have experienced recurrence, and it was a surprise to me just learning that it doesn't always recur with the same characteristics as your original tumor. It could, but it doesn't have to be. And so that was news to me to realize that, it can take on different characteristics and adapt to, responding because you've been through so much treatment already. And then secondly, I was naive to think, if I was diagnosed with stage 2B, that of course I would become stage 3 before going on to stage 4. And that was another myth that I didn't realize. I thought it was like, oh, well, there's progression. I just follow the steps, and there's opportunities to catch it. And that's not always true either. So I appreciate you kind of talking about, again, the blanket terms of, what does recurrence actually mean? And so
That's right. And
yeah.
and to elaborate a little bit on that as well is recurrences, as I mentioned, when they happen locally, right within the breast, or they happen regionally within lymph nodes, there's a hope and an opportunity to achieve a second chance of cure, right? Where it can be retreated again, operate again. Now, the good news is that, these local recurrences, it typically don't happen so often, but again, when they do, there's a second chance of cure.
Hmm.
And even in distant recurrence, there is a small but real chance that the recurrences can be isolated. We call
Mm.
that oligo
Mm.
metastatic recurrence. Oligo meaning few. So if recurrence happens in just one spot in a lung, or one spot in the liver, one spot in an area of the bone, we can hope to eradicate the disease by treating it locally, maybe with radiation, maybe with surgery, and hope it doesn't come back again. But the reality is the risk of another recurrence down the road is unfortunately still there and still
Yeah.
high.
And so, what are some of the statistics around recurrence?
Mm-hmm. Yeah. So it obviously depends a lot on the stage.
Mm.
And so, this question, I like this question because it allows me to then introduce or talk a little bit more about how we stage and what does it really mean to
Mm.
stage.
Hmm.
Um, so really, as well as physicians in general, but in this case as oncologists, what we all try to do is predict the future, right? We try to predict what's going to happen in the future. And in this setting in oncology, well, we try to predict what are the chances that the cancer is going to come back in the future. That is the statistics you're talking about. So, on one extreme, if we are talking about a very small tumor in millimeters in size, lymph nodes that are not affected with cancer, right? The cancer has not spread to lymph nodes. The biomarker means, what made this cancer grow. Is it estrogen? Is it independent of estrogen? Is it HER2? Right, we can talk about the different kinds of breast cancers. um, is another factor, and also sometimes the machinery, right? Which means, you imagine, if you look, you open the hood of a car and you see what's the engine look like. Some cancers we can look and we can see that they are faster growing, and others maybe we call, kind of more aggressive than others. Really, what that really means is that we can kind of tell whether the cancer is going to behave badly and have a higher chance of recurrence. So we put all these pieces of the puzzle together, and kind of use it as a crystal ball, if you will, and try to predict, are the chances of recurrence less than 5%? Typically stage 1 tumors tend to be less than 5% of recurrence, or is it roughly 20 to 30% chance of recurrence? And stage 2s and 3s can get to that number, and even within stage 1, 2s, and 3s, that number can vary, right? And there's a lot of other factors that we use, including how did the tumor respond to the treatment. So in general, if we look at breast cancer, roughly 20 to 30% of the time there may be a recurrence, lower in stage 1 and higher in stage 3s.
Yeah, no, that's really helpful. And, again, not to, I think we're always honest on our podcast and in our literature as well. And so, sometimes hearing these statistics can be very scary, thinking, oh my gosh, I'm that 5% or I'm that 20 to 30%, but it doesn't necessarily mean you are going to have a recurrence. It's just what the statistics have
Exactly
been
right.
showing over a lifetime. And, to your point, I think one of the other factors too, I know in other episodes we've discussed, genetic testing and other sorts of things that can play into some of those decision-making roles. To use my own experience, I was a candidate for neoadjuvant chemotherapy. So I had chemotherapy before surgery, and that I think it was like, a blessing in disguise, so to speak. I mean, I did not enjoy going through chemotherapy, but it gave my oncologist an opportunity after surgery to see how well that particular tumor responded to the chemotherapies that I was on. And unfortunately, I did not have a complete response to the chemotherapy. And so while I was devastated and was in tears and was like, oh my God, we didn't get
Mhm.
all the cancer, he was like, no, 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 we did the surgery. We got the cancer out. But now this just tells us more information about how your body's responding. And that's good information to have, whether you had a complete response or not a complete response. So I think that's, again, to what you were saying, the more information in the factors, and how that leads into potential higher risk for recurrence and how we can be
So
proactive.
so that's exactly right. I think, back in the day, many decades ago, we just used to do surgery on everybody, right? And then use these factors that I described to make an educated guess of what are the chances that the cancer would come back, and those patients who would have a high risk of recurrence would undergo what we call adjuvant chemotherapy, just basically systemic treatment to reduce the risk of recurrence. And now, understanding how the cancer responds to treatment basically has allowed us to refine that guess, that educated guess, refine that guess, and now where we thought all patients had roughly 20% risk, 15 to 20% risk, now we can refine that risk and therefore use that piece of information to then optimize management in the future. Do we need more treatment? Do we need a different kind of treatment, or do we stay the course?
Mm-hmm. And I'm sure it varies by these biomarkers and characteristics that you were describing. But is there like a window, so to speak, to determine whether or not, you're at more high risk for recurrence, whether it's, 1 to 5 years after your initial diagnosis, or in some cases, could it recur even like 15, 20 years down the line?
Definitely. Thank you for asking that, because now really what we're talking about is, the patterns of recurrence, right?
Mm-hmm.
How do some cancers sort of behave, right? And granted, not all cancers read the book and they don't necessarily act in the same way, but generally speaking, when we're talking about um, uh, higher risk cancers, so now with cancers that uh, um, well, let's say for example, grade is a factor that we also use to determine how aggressive or the risk of recurrence of cancer can be. And grade really means that a pathologist can look under the microscope and assess whether a tumor tends to behave badly, like maybe and cause trouble, versus behave well and tend not to cause trouble, right? We also use the terms well differentiated and poorly differentiated. So cancers that tend to be more aggressive, and cancers like that tend to be what triple negative breast cancers, or some grade threes, estrogen receptor positive breast cancers. The risk of recurrence is higher early on, right? Early on, meaning in the first 2 to 3 years of recurrence. If a recurrence were to happen, it tends to happen more often early on, and more so triple negative than ER positive, but it happens early on. Whereas, what is unique to a hormone receptor positive breast cancer or estrogen receptor positive breast cancer, the kind of the most common type of breast cancer that is, driven or fueled by hormones. This type of cancer is notorious for having a recurrence pattern that can persist over a very long time, right? And in general, sort of lower risk ER positive, less than 1% per year of the women may or men may experience a recurrence. But when we're talking of very high risk breast cancer, such as patients with maybe more than four or more positive nodes and larger tumors, these types of cancers, may recur at about 4 to 5% per year, and it may persist over a very long time. And actually, more than half of the recurrences of breast cancer for ER positive can typically occur after year 5.
Oh, wow. Okay. No, that's good to know. I fall into that category as triple positive. And so,
I see.
I think as we are, you know, so excited to be like under surveillance or in survivorship mode, a lot of us are also on hormonal therapies, for the next 5 to 7 to 10 years, depending on like, what the data keeps coming out at San Antonio Breast Cancer Symposium to see, what are
Mm-hmm.
the benefits. And I almost fell off the examine table when my doctor told me I might be on these medicines for like 10 years, because everything up until now was like, okay, we'll do 6 months of chemo or 1 month of radiation. And then now I'm on a treatment plan for the next 10 years. And that was, again, to reduce the the likelihood of recurrence. Obviously, we can't prevent anything, but to reduce the likelihood, which I really appreciate. Which leads me to my next question around like lifestyle changes or other things that, us as patients can feel empowered to do to
Mhm.
reduce and mitigate the risk of a recurrence.
Absolutely. I mean, I think although we can't um, totally guarantee the prevention of a recurrence, the good news is that there are things that we can do to to maximize our chances of cure and reduce the risk of recurrence. And it's doing exercise and having a sort of a healthy lifestyle, not only has been shown to improve the tolerability of some of our medications, sort of reduce side effects and ensure we maintain sort of healthy body. Um, uh, there are studies that have suggested, right? And I think I can't necessarily say that it's definitive, but there are studies that have suggested that there, may be a contribution to the reduction of the risk of recurrence. But more importantly than that is also the avoidance, right, of potentially other cancers that as cancer survivors or even health individuals who do not have cancer can avoid, or reduce the risk of another cancer. Healthy lifestyle, diet, and of course, avoiding toxins like smoking.
Yes, absolutely. And you make it sound so easy, right? Like who doesn't want to eat healthy and exercise? I a tidbit that I started telling myself to kind of reframe because, I think in our culture, in the US, we just go, go, go. We're so busy.
Mm-hmm.
And so I started telling myself if I have a minimum of 8 hours, because I know I work way more than 8 hours at my job per day,
Mm-hmm.
I deserve a minimum of 30 minutes that I can give to myself. And in those 30 minutes, I want to walk
Mm-hmm.
briskly. I want to get on my Peloton. I want to do a yoga class. I want to do something that, if I'm giving my employer all of this time for me, what am I doing for myself? And just that reframing was like,
Mm-hmm.
I'm in the car commuting for 45 minutes each way. Like I'm doing so much outside of taking care of myself. And so
Mm-hmm.
how can I, encourage me to like take care of me and
Yeah.
feel better and have energy and fight the fatigue and a lot of the symptoms that come with, some of the treatments that we're on. So I appreciate that.
And it reminds me also of when you say taking care of me, it reminds me of actually a study that was done in University of Michigan many years ago that looked at causes other causes of death after a patient has had a history of breast cancer, and believe it
Mm,
or not, it was actually an early stage patients who were diagnosed with early stage breast cancer, and the most common cause of death due to cancer was actually colon, not breast. And I
interesting.
think what's important about that, it's not that patients with breast cancer are more likely to have colon cancer, but rather that you should continue to undergo surveillance and screening strategies for other cancers as we would otherwise recommend to somebody who has not had breast cancer. So it's very important.
That's a really good point. Another question that I had also, because we're talking about recurrence or, even progression in the metastatic setting, how do we know when to go to our doctor and say something's not right or I'm concerned or,
Mhm.
I have when I first got diagnosed, like everything concerns me. Like I would sneeze or cough and I'm like, oh my God, it
Mhm.
metastasized. Or I had a migraine headache because I had a stressful day at work and I was like, oh my gosh, it moved to
Mhm.
my brain. What are some of
Mhm.
the characteristics or symptoms that you could describe and let us know, like, when should we like raise that flag and ask our doctor?
That's right. Let me address the second part first, actually, because I think it's incredibly important that you work with your oncologist and you have a strong partnership and open line of communication for anything, right? The and also before I address right the what do we look at to um to uh to surveil for cancer recurrence, is we have to understand what are the current recommendations and why, right? So breast cancer is a disease type that currently, studies have been done in the past, numerous studies have been done in the past to evaluate, let's call it aggressive surveillance, whether it be with scans, x-rays, or ultrasounds, or blood markers. And when we evaluate the strategy using all these modalities versus just simply living life and going to the doctor once in a while, right? Whether it be initially every 3, then every 6 months, and having them examine you, physical exam, and you talking about all of your concerns, symptoms, or signs that you may see. That whether we do scans aggressively or not, that there is no difference in the overall outcome of patients, and that has led to the current sort of guidelines of we don't need to do scans, we don't need to do imaging. And part of a significant contributor to this sort of decision and recommendation has to do that these tests that we have previously been tested can be inaccurate, right? And the last thing that you want to do to a patient who is free of recurrence is tell them that we found something on a scan that may be cancer, because that can lead, well, not just to the high anxiety, but also to sometimes interventions that lead to an unnecessary biopsy and even potential complications to ultimately prove that that was just a small scar, possibly of radiation, for example. Um, but so therefore, right now, what do we do is, we go home, we live life, and if you're right, recurrences can happen in any part of the body, and they can manifest in many different ways. Um, One of the more common sites of recurrence is bone. So really any unusual type of bone, and the key word here and difficult part is unusual, right? What's usual, what's unusual, right? And who doesn't have pain here and there? And this can raise, concerns. And that's why I said it's important to have an open dialogue with your physicians about any pain, about any concern, because it may be that initially, okay, we'll just try good old fashioned anti-inflammatory medications and observe the nature of that pain or discomfort. Now, granted, it certainly also depends on how severe it is, right? Sometimes it's severe enough that, oh, we're going to look immediately. But sometimes time will tell us that, okay, the pain's gone, right? And we almost have to expect that these things will happen. As you mentioned, a cough, right? How often do we not have upper respiratory tract infections and have a cough that lingers and lingers forever? And here it's again the dialogue with your physician that ultimately triggers, okay, should we do a scan now or later, right? Um, any lumps or bumps, right? We talked about cancer potentially coming back within lymph nodes, right? That typically manifests as a lump, and it could be in any part of the body. For some cancers, unfortunately, it can spread to the brain, and in those, right, any unusual discomfort and neurological symptoms like visual disturbance or pain, these are kind of, or headache, these are kind of things that should be brought up to the doctor.
Fantastic. You bring up so many excellent points. And, at the end of the day, we know our bodies the best. And I think having that
Mm-hmm.
open line of communication with our oncologist and, even our primary care, all the doctors that we see, just to
Mm-hmm.
make sure, like, okay, you've been treating me for so long now, like this is my baseline. And so when I am bringing something to the attention, it's just nice to be able to have a sounding board and then develop a plan to see, okay, is this, something that we should just monitor, as you mentioned, with the anti-inflammatory options, or, is this more severe where we do need to order scans? And I would also share also in our communities, I talk a lot to, these moms who are just like overachievers in everything they do. And we always like want to muscle through, like, oh, it's just nothing, it's nothing. Or, of course, I'm fatigued and tired. I'm chasing 3-year-olds all day. Or, of course, my back hurts. I'm picking up my toddler. So, I think it's that idea of that unusual piece, right? And so, really taking that moment, if you take, going back to my earlier comment, if you take those 30 minutes a day just for yourself to like do the inventory, how are you doing? What is your normal? What is unusual? I think is really important. So I appreciate you
Sure.
bringing that.
Hmm.
Um, kind of going along these lines of like recurrence and knowing some of the symptoms, I think another common question that we hear is, how do I know that the treatments that I'm on are working? So I think
Hmm.
this kind of goes to, okay, I've been on, these aromatase inhibitors for so long, or maybe I'm on, various chemotherapies for my metastatic disease, et cetera. How do I know that it's actually
Hmm.
working? So what do you tell those nervous patients?
Yeah, and I think it's very, very natural to have this type of question and curiosity because, what's interesting of what we're dealing with here is if we compare this to other scenarios, let's say diabetes, right? With diabetes, when patients are treated for and their blood sugar is lowered, number one, they will feel better, and number two, you will see a number go down to where it's supposed to be, right? So patients tend to be very compliant, adherent, and say, great, I feel better, right? And so I'm going to continue, and so the treatment's working, right? They see it. Treating blood pressure, same thing. Sometimes the high blood pressure may make you feel bad. Sometimes they say symptomatic, right? You don't feel it, but at least you see a number periodically go down. And then the third one is like pain, right? Of course, if you're having pain and you get a pain medication, it works. It's working, right? Here, unfortunately, how do we know it's working? It's difficult to tell, and the reality is that the uniqueness of this type of breast cancer, specifically, right, the estrogen receptor positive breast cancer, um, when when there's disease, microscopic disease, and we pretty much, when we treat patients with early stage setting, we pretty much assume that everybody has microscopic, undetectable disease, right? We assume that it's the reason why we recommend these endocrine therapies, right? We assume it's there. We want to be on them to maximize our chance of cure. And we don't have good ways uh, currently in the clinic to be able to identify whether the disease is there. Right, scans are not sensitive enough. Sometimes the cell might be, sleeping in the bone, sleeping in the liver, and won't shed anything. It won't, regular blood test or protein test that we normally use, tumor markers, are unable to detect that. And our medications, what they're doing is keeping it that way, right? They're keeping it dormant, keeping it silent, and preventing it from waking up, right? So, the short answer to your question is, unfortunately, we really don't know if it's working. We're just maximizing our chances that our treatments are keeping it that way.
Yeah. Yeah. I mean, that was eye-opening to me as well, knowing, medicine isn't a perfect science. And, as a kid,
Correct.
you went to the doctor and they like fixed everything. Like you broke an arm, they put you in a cast and you're all better. And all these things, they fixed everything. It wasn't until I got cancer that I was like, oh my gosh, like it's so complex
Hmm.
and challenging. Absolutely. You talk a little bit about these circulating tumor cells, the ctDNA. Can you, again, I should have asked you this at the top of our conversation, but can you give us a definition about what ctDNA is?
Absolutely. So all of the basically what we've talked up until now
Hmm.
is, what the current recommendations are and what some of our challenges are, right? To determine, some of these things. How do we know if we still have disease? How do we know if the disease is recurring? How do we know if our treatment is working? And so, you know come here. So now, what we have is a technology that may be able to address some of these challenges. So to clarify, right, some of the terms or that you technologies that you may have heard about: circulating tumor cells is, well, what it sounds like: cells that can potentially be picked up in the blood. this type of technology has been evaluated extensively in the past, and really, unfortunately, has not proven to be accurate enough in to improve some of or address some of our current challenges, meaning that um, patients who may have ultimately experienced a recurrence may not have detectable circulating tumor cells in the blood. And conversely, actually, some patients who may have circulating tumor cells detected in the blood may not experience a recurrence down the road. And come in this newer technology called circulating tumor DNA. So, circulating tumor DNA basically exploits one of cancer's weakness. And that is that when cancer is present and active in the body, it tends to release some of its byproducts into the blood, fragments of its DNA. So, where this technology has already proven to be um, largely helpful is in patients with metastatic breast cancer, where now we can do a simple blood test and we can identify and detect and characterize what are the particular sort of pieces of the DNA that is in the blood from the cancer, and it can allow us to make decisions and informed decisions for patients in terms of how to manage them, right? Maybe a specific therapy over another. Um, and so, however, but this technology, which is really detecting disease at the molecular level, right? Not at the necessarily at the imaging level. The first sort of generation of this type of technology was not accurate enough to be able to monitor the disease or even detect the disease in early stage setting, right? In stage one, two, or three. And now with improved sort of technology um, and processes of detecting DNA in the blood, there's a one called that's basically we call it tumor informed circulating tumor DNA, which is, imagine if we are able to learn as much as we can from the genomics of the tumor, meaning what were the broken genes that the cancer was born with, the mutations that the cancer was born with, know all of its DNA sequence and compare it to the patient's blood, meaning what was the DNA results that the patient was born with, and we can compare and contrast. And now we can basically create a like a molecular barcode or a specific molecular alterations that we can use to test each patients with cancer sort of blood to then achieve that sensitivity, that accuracy to know if the disease is still there or not, and monitor the treatment response. And so that's the type of technology that we're now testing in the clinic and potentially using to inform decisions that clinicians and patients have to make.
That's incredible. I love hearing about the science and just like I feel like it's moving at warp speed as well. I feel like every year there's more clinical trials coming out, more data being presented. We're finding out more about, the molecular side of cancer, how sneaky and tricky it is. We always say like, why can't they just follow the rules in the books, just like you mentioned?
Mhm, mhm.
But this has been incredibly helpful. I'm trying to think. Is there anything that we haven't discussed that you would like to share, or topics that we haven't covered yet that you would like our audience to know?
Yeah, I think just to kind of reiterate some of the things that you said, so we haven't figured everything out yet. We have not. There is a lot of room for learning and understanding cancer so that we can, you know, um, continue to reduce breast cancer mortality, right? Because, unfortunately, despite our best efforts, almost, 45,000 patients a year die of breast cancer. As we're evaluating this new tool to in the hopes of making better decisions for patients, whether it be um, identify patients that are at risk of recurrence and offering the opportunity to intervene to possibly prevent the recurrence that that is likely to happen if there's no change in the course of treatment. um, right now is a time where we need efforts from all sides, right, to be able to test the strategy of, can we use circulating tumor DNA in the surveillance setting to identify patients who we need to do an intervention, right? And so there's several clinical trials running out there across the country. One being a study called the DARE clinical trial, we're led by Lajos Pushtai in Yale Cancer Center, but again, many sites open throughout the nation, and this study is specifically using Signatera surveillance in patients that have been treated with curative intent treatment. And if patients are found to have a positive result, then they are offered the opportunity to enroll in the study and be treated with a regimen that is being evaluated to see if it can, well, clear the circulating tumor DNA that's detected, and can it prevent recurrences that would have otherwise happened. What we are also seeing as patients are undergoing surveillance with circulating tumor DNA is that it can detect local recurrences where patients can have, as I mentioned, sort of the opportunity to eradicate the disease again. And also opportunities where treatment can be optimized. So sometimes patients are recommended to undergo the most effective treatment, aromatase inhibitors. But sometimes, whether it be because of fear of the potential side effects or the feeling of the side effects that one can feel, sometimes the medication is ultimately not taken, and instead, opt for another medication, let's say tamoxifen, or sometimes patients come off treatment altogether. And in that scenario where we know that about up to 20% of patients may not be completely adherent to therapy for many different reasons. So one big question is there an opportunity um, to improve adherence by having a positive result, and now would a patient be more willing and likely to take their endocrine therapy in the hopes of preventing a recurrence that would have happened if you don't take the medication, right? And so those are things that patient advocacy and patient reported outcomes and thoughts from patients is going to be important now more than ever, right? Because we want to understand, with these type of strategy of surveillance, how are patients feelings, and not just patients who have negative results, but patients who have positive results, patients who have
Mm-hmm.
positive results and we haven't been able to find the disease yet.
Mm-hmm.
Sometimes we'll find the recurrence, sometimes the recurrence hasn't happened yet.
Right. Right. All really good points. And I think, tying this to what you were saying with the open communication with your medical care team, with your oncologist, you don't need to suffer in silence either if you're dealing with all of these symptoms and side effects. I think there was a point, especially when I was told to be on some of these drugs for up to 10 years. It's like, okay, is this just how my life is going to be now with hot flashes all the time and joint pain all the time and moodiness all the time? And it's like, well, no, let me talk to my doctor and see what are things like acupuncture or some other natural and holistic opportunities to make the quality of life a lot better. And so I really appreciate and commend like all the work that you're doing, Dr. Rodriguez, and with these clinical trials to, really center around the patient and, hear their voice and hear everything that they're going through to try and get better outcomes.
Yeah, and of course, if you're interested, one can Google DARE, DARE, and clinical trials breast cancer, and then that clinicaltrials.gov will offer you a list of sites that are open, and as well as a phone number or email that one can reach out to.
Fantastic. I'll definitely put that in the notes of the podcast so anyone listening or watching can have those links easily accessible. This has been such an enlightening conversation, Dr. Rodriguez. I'm over here like taking notes for anyone who's watching the video recording. I got my notebook going. But this has been so delightful. Thank you so much for taking the time to be on our podcast, Breast Cancer Conversations, and sharing your wisdom with our community.
Thank you. Thank you so much for what you do, and thank you for the opportunity.
And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast are from personal experiences and are not a substitute for professional medical advice. You should always contact your medical care team. If you're looking for specific topics or would like to be a guest on our show, please feel free to reach out to me. My email is laura@survivingbreastcancer.org. Until next time, keep on thriving.